Hello to everybody. It's Wednesday morning, it's 10 o'clock, so it's Enjoy Science. So thank you to all the attendees who are all the time around us, to all MD Anderson family. And of course, I want to thank to Alessandra Ferraelli, with whom I co-host this wonderful series. I want to thank to Ellison Gard, Valerie Jimenez, Liz Kent, and Laura Adame, who are doing all the wonderful work behind the scene, and to Dr. Giulio Draeta, who basically is supervising all this series. And today it's a great pleasure. It's a great pleasure because I have to introduce in front of you Dr. Hagop Kantarjian, who basically don't need an introduction. So he is chair of leukemia department, and as you know very well, he is basically one of the most well-known leaders in leukemia, who is doing what is supposed to do a clinician, saving a lot of lives. Only 2 points I want to say about Dr. Kantarjian and why I prize him. Because personally for me, he is an example that doesn't matter where you are born. If you are working hard, if you are clever, if you are doing your job at the best, you became one of the most famous clinicians in the world. And in fact, he is born and trained in the beautiful country of Lebanon, and from few years ago, to be fair, 1983, he came to MD Anderson when he established himself like one of the best doctors. And the second, very important, it's extremely important to be at the top of your job. But Dr. Kantarjian surrounding himself by a school of leukemia physicians. There are a lot of people surrounding him, trained by him, people who consider himself a mentor, who are basically now widespreading Dr. Kantarjian type of treating a patient with leukemia. And with this, let's have basically the show run by who deserve it. Hagop, thank you very much for being with us. Good luck with your presentation, and we are very curious about your data.
Thank you very much, George. So I understand we're competing with the presidential inauguration, so I'll try to finish by 9:50. But I thought that it's very important for the people who are in the daily grind of the work and who may not appreciate progress in leukemia or in cancer in general, that we have a review that gives them a flavor of where we were and where we are today. So I show the MD Anderson as it was inaugurated in 1954, and it moved from the stables and the estates of Jim Baker, which were the host of the MD Anderson from 1946 to 1954. In 1954, this is all we had, and this is important to compare to what we have today. So I show here the original T-shaped MD Anderson, or what some people call the Pink Palace of cancer research. And you see how much it has grown since then. Now, Dr. Freireich came to MD Anderson in 1965, and he established the Department of Developmental Therapeutics then, which became the largest program of cancer research in the world, with about 160 faculty. And but when he came in 1965, he had to fight many dogmas of the establishment, and this is documented in many of the email of the exchanges in the literature. So, for example, Dr. Damashek told him that it was unethical to treat children with acute leukemia because you need to let them die with dignity. And then later on, Dr. Crosby, another eminence in hematology, told him that it's unethical to treat older patients with leukemia and that they should be let to die with dignity. As you know, Dr. Freireich fought these dogmas, and today he has established many of the principles that we rely upon in the treatment, not only of leukemia, but of cancer in general. So I'm going to use leukemia as an example of the progress in cancer rather than to highlight it uniquely, because I think there's progress across all cancers, and it happens in different forms and steps, breast cancer, lung cancer, melanoma recently, and many of the others. But to give you a simple highlight, and I'm going to make the presentation very simple showing you what exists today and what existed then. So we divide the the leukemias into acutes and chronic. The acutes essentially have a maturation arrest with more than 20% blast, and these include AML, ALL, and then the chronic leukemias, there's no maturation block, but there is excessive production and long-lived cells. And so the blasts in the bone marrow are 5% or less, and this constitutes CML and CLL. It's also important to note that when Dr. Freirach came in 1965, the cure rate across all leukemias was 0%. So there were no cures, there were no treatments. Fast forward to 1981 when I became a fellow at MD Anderson, there was major progress where the cure in the acute leukemias was reaching about 20%. There was still no progress in or cure in either chronic myeloid leukemia or chronic lymphocytic leukemia. And through the leadership of Dr. Freirach and Dr. Keating and many others, MD Anderson has developed most, if not all, of the important steps in the management of the leukemias. In acute myeloid leukemia, we now have 10 drugs that have been FDA approved, almost all of them through the leadership of the MD Anderson faculty. The same applies for acute lymphocytic leukemia. We have participated and led the discoveries of the 5 tyrosine kinase inhibitors in chronic myeloid leukemia. And the ibrutinib venetoclax was developed here at MD Anderson, and I'll show you that it has now become a standard of care. So very few of us still remember the past. We have to remember that our knowledge is very contemporary, and our medical knowledge doubles every 2 years. So the only people who may still remember the past as it was before the year 2000 are Dr. Freirach, Keating, Jordan Gutterman, Bill Plunkett, Walter Hittelman, Michael Andreeff, and Estrop. Other than these people, most of the other faculty in leukemia are junior and see the leukemias as easy to treat rather than very difficult leukemias as they are. So here I show some progress in the therapies of leukemias. With hairy cell leukemia, we developed the cladribine rituximab, which now cures 90% of the patients. We also developed the non-chemotherapy regimen in APL with atraarsenic trioxide, which now cures about 80 to 90% of the patients. The same applies to the core binding factor leukemias. And more recently, I'll show you the data with the new intensive chemotherapy regimens, which I think are going to cure much more than what is reported in the literature. AML in the older remains a difficult situation, but with the discovery of venetoclax, we think that we are going to improve the 5-year survival to about 50%. ALL is an area where major progress has happened, and now we can cure probably 80% of the patients. And then the chronic leukemias, which are now either functionally or molecularly curable with the treatments that are available to us. So let me start by first saying that the outcome of the leukemias is very dependent on the microenvironment or the environment where the patients are treated. Historically, people believed that anybody can treat an acute leukemia until a lot of pieces of information became available. So this is a national cancer database on 60,000 patients, where it was shown that actually the mortality in the community practice is twice as high as in the academic centers, and that reduces the survival by 10%. Keep this 15% survival and 25% survival in your mind for when I show you the data from MD Anderson. And similar data were reported from California, where NCI designated cancer centers had a mortality half as that of non-NCI designated cancer centers. So it is not true that anybody can treat leukemias. Leukemias are rare, they require expertise, but very importantly, they require supportive care. And here I show the benefit of the environment, and this is credit to our emergency center physicians, our ICU physicians, and the support groups such as infectious disease, pulmonary, renal, and others. At MD Anderson, the 4-week mortality is not 12 to 29%. It is down to 5% with intensive chemotherapy in younger AML and down to 2 to 3% with the low intensity therapy in older AML. And now our cure rates, I'm going to show you in the younger AML, are probably going to exceed 50 to 60%. And the 5-year survival in the older AML is going to be close to 40 to 50%. So I'm going to start with the easy leukemias. And I put the easy leukemias as hairy cell leukemia, APL core binding factor, chronic myeloid leukemia, but also today I've included CLL. Remember, CLL in the textbooks is still called as incurable. This is not true anymore. I think we can cure most patients with chronic lymphocytic leukemia with 2 oral targeted therapies for a duration of treatment of 2 years, and I'll show you this. Let's start with hairy cell leukemia. So in 2000, we developed the cladribine for 5 days, followed by rituximab weekly for 8 weeks. So a very simple treatment. And the complete response rate is 100%. The 10-year disease-free survival is 80%. And the 10-year probability of survival is 90%. You cannot do better than this. This is now the standard of care in the hairy cell leukemia. Also in 2000, realizing the powerful benefits of atra and arsenic trioxides in acute promyelocytic leukemia, we designed a non-chemotherapy regimen which we reported on in 2002, and this included atra and arsenic trioxide followed by 8 months of maintenance. And on this slide, I show the survival at MD Anderson. So now in green, the estimated 10-year survival in the younger patients is 90%. In the older patients, it's close to 85% because some of them die from secondary malignancy. And this has been reproduced in the randomized trials. And in 2012, it was confirmed in a paper in the New England Journal of Medicine by the Europeans. So what was standard of care in terms of our research protocol at MD Anderson in 2000 became a standard of care in 2012. And this is a message that I'll keep repeating, that is our research really benefits the patients for about a decade before it becomes a standard of care. This is the core binding factor leukemia, so in version 16 and 821. Here we did not make a major discovery, but we put the chemotherapy drugs in a better sequence as they did in pediatric acute lymphocytic leukemia. And we relied mainly on gemtuzumab ozogamicin, which was Mylotarg. And the gold curve shows our estimated 10-year survival of 80% in the patients who were treated with the fludarabine, Ara-C, GO, or idarubicin, which was an amazing feat. Now let's move to chronic myeloid leukemia. So as you know, this is a disease that's driven by the Philadelphia chromosome BCR-ABL abnormalities. And before 2000, people who treated CML knew that the disease was fatal with a poor prognosis, a 10-year survival of 10%, and the only curative option was allogeneic stem cell transplantation. In 2000, we developed imatinib, the first of the BCR-ABL kinase inhibitors, and this was followed by the development of the second generation tyrosine kinase inhibitors, dasatinib, nilotinib, and bosutinib, and finally ponatinib, the third generation, very powerful one. So now we have many options for these patients. They live their normal life. They have an excellent prognosis. I'll show you the estimated 20-year survival from MD Anderson. And if all fails, then the few of them will go to an allogeneic transplant. This slide shows, so imatinib was introduced in 2000. So we have a follow-up time of about 18 to 20 years. What I show is the progression of the improvement. So the white curve is hydroxyurea or busulfan. The blue and fuchsia curves are the interferon era. The green curve are the patients who were started on interferon and were able to access imatinib or the TKIs in 2000. And the top three curves are the survival data with the BCR-ABL kinase inhibitors. The top one in white are patients where we exclude non-CMR related deaths. The red curve are survival with death from any cause. So what you see is that now the patients actually live their normal life, and we confirmed this in what we call a relative survival analysis, where we match the patients for the age. And what you see is, in fact, the mortality from chronic myeloid leukemia is down to 0.5% per year, which is amazing considering a disease that used to be invariably fatal within an average of 6 years. Now we're trying to stop the treatment and discuss treatment-free remission. So whenever the patients are in what we call a deep molecular response, so a 4-log reduction of the disease for more than 3 years, we try to stop the therapy. And what you see is that half of the patients can relapse, but the other half are cured. So you either have to take the pill for a lifetime, as you do for a blood pressure medicine or diabetes medicine, or if you achieve a durable deep molecular response, and at MD Anderson we define it as a duration for 5 years, because then the cure rate is not only 50%, it goes up to 85%. So what you see here is the unfulfilled goal of treatment-free remission. So today we can achieve it in about 40% of the patients. And of those 40%, half of them are cured. So 20% are not only functionally cured, but also molecularly cured. And what we are doing today is trying to improve on this. So we have a regimen with dasatinib at half the dose to reduce the toxicity. We tried adding venetoclax, and it does not seem to work. But what might seem to work very well will be the addition of oral decitabine, because other than TKIs, decitabine is one of the most powerful anti-CML drugs. So this is the new study that will be opening soon. Let's move to CLL research. So as I mentioned, now I classify CLL as an easy leukemia, and this is thanks to the efforts of Jan Berger, who developed ibrutinib originally, and then the efforts of Dr. Michael Keating, Bill Weirda, and Nitin Jain, who have developed the ibrutinib venetoclax combination. So remember, before 2014, we had the chemoimmunotherapy with rituximab. But since then, we have the combination of the BTK inhibitors, in particular ibrutinib, but there are better ones, and the combination of venetoclax. So this shows that unlike the traditional dogma that CLL is incurable, Dr. Keating's group had shown that, in fact, the patients who have immunoglobulin heavy chain mutation, and who tolerate the FCR, and this is about a third of the patients, can be cured with a plateau of 50% at about 10 to 12 years. So in fact, CLL is potentially curable. But now I'm going to show you that, in fact, when we developed the Bruton tyrosine kinase inhibitors as well as the BCL2 inhibitors, we realized that these drugs were the two most powerful drugs in chronic lymphocytic leukemia. So we came up with the idea of combining them for a finite duration of therapy. And Dr. Jain has already published in the first 40 patients in the New England Journal of Medicine, and this is the update that he was kind to give me in the 80 patients who were treated. So this applies to the total population of patients. What you see is almost everybody achieves the complete remission. Almost everybody also achieves an MRD negative status, and this is the update on the survival. So now we have an estimated 4-year survival and progression-free survival, which is close to 90% of these patients. And we're starting to stop the treatments in the patients who are in a deep molecular response, and the patients are not relapsing. So I think we have the tools to cure chronic lymphocytic leukemia today quite effectively with 2 non-chemotherapy drugs, which are given orally for a duration of 2 years. And this shows that once you have effective therapy, as in prostate cancer, as in APL, as in many of the other cancers and hematologic malignancies, you nullify the adverse effect of the previous prognostic factors. So in the context of ibrutinib venetoclax, the progression-free survival is very similar, whether you have immunoglobulin heavy chain mutated or not. But more importantly, the deletion 17 or P53 patients appear to be doing quite well. And these were patients who used to do very poorly in the context of the pre-times when we used FCR or other such modalities. Now I'm going to show you the intermediate leukemias, and here I place acute lymphocytic leukemia and younger AML. So in acute lymphocytic leukemia, as you know, in childhood leukemias, they use about 15 chemotherapy drugs for about 3 years, and they can cure about 80% of the children, but many of them become incapacitated as a result of the toxicities of the chemotherapy. This shows the MD Anderson data actually from 1985 to 2020 to show you that we have improved the 10-year survival from 20% now to about 50%, and this is across the board. So next I'm going to show you the subsets. Now the question is, why do we do worse in adult ALL than pediatric ALL? And it's related to, in fact, a different incidence of the favorable versus unfavorable ALLs. So 50% of childhood ALLs are hyperdeployed or ETV6 ranks 1, and these do very well, and they are uncommon in adult ALL. And then 50% of the adult ALL are Philadelphia positive or Philadelphia-like, and historically they used to be quite unfavorable. Now keep this in mind because I'm going to show you a completely different picture over the next set of slides. So why is success happening now rapidly in adult ALL? It's because we added the BCR-ABL tyrosine kinase inhibitors to chemotherapy in Philadelphia positive ALL. And we started adding the antibodies targeting CD20, but more importantly, CD19 with blinatumomab and CD22 with inotuzumab. CAR T cell therapy is very important in myeloma and lymphoma, but I don't think it's as important in ALL. It may be important in the salvage setting. So in 1992, we developed the hyper-CVAD regimen at MD Anderson. We changed CNS prophylaxis all to intrathecals. In 2000, we added rituximab to Burkitt and to acute lymphocytic leukemia. And in 2000, we started adding the TKIs to Philadelphia positive ALL. But I think the biggest breakthrough has been the development of the antibodies, both inotuzumab and blinatumomab in adult acute lymphocytic leukemia. So let me take you through this journey. So first, Philadelphia positive ALL. Before 2000, it was incurable except with an allogeneic stem cell transplant. And even then, the 3-year survival was about 30 to 40%. So not a very good outcome in these patients. This shows the data at MD Anderson. Since we started using the TKIs in 2000, this is imatinib. And in 2010, this is where we introduced ponatinib with the hyper-CVAD. So today, if a patient with Philadelphia positive acute lymphocytic leukemia comes to MD Anderson, actually we tell them that they have a very favorable prognosis and they may not need an allogeneic transplant. So I'm going to go to what we are doing today. So because we noticed that many patients relapsed with the T315I mutation, and because we knew that ponatinib is the most powerful of the TKIs, we combined hyper-CVAD ponatinib in 2010. And this is the updated estimated 10-year survival, which now shows that about 75% of the patients are cured. So to take you through the data, we have about 100 patients now treated. The CR rate is universal. MRD negativity is universal. PCR negativity occurs in 84% of the patients. Those who do not become PCR negative, we advise them for transplant. And what you see is the estimated 5-year survival of 75% in these patients. Now, can we do better than this? We can. In fact, what we realized is that both blinatumomab and inotuzumab, which were developed through the leadership of MD Anderson, were more powerful than chemotherapy in the setting of refractory relapse Philadelphia positive ALL. So the Italians combined dasatinib and blinatumomab first in this disease, and they reported that they had, in the older patients, a wonderful estimated survival probability of about 85 to 90% at 2 years. The problem with this study was that they used dasatinib, which is an inferior TKI, and they started blinatumomab 3 months into the treatment. So at MD Anderson, we corrected these two variations. We started using ponatinib up front, and this is our initial experience in the 22 patients that were treated. Again, we have an estimated survival rate of 80% in these patients, and we think this is going to be another breakthrough in the management of Philadelphia positive ALL. Now, as I mentioned, MD Anderson led the development of inotuzumab on an investigator IND, and we also led the development of blinatumomab in the randomized trials. And this shows the comparison of blinatumomab to intensive chemotherapy in the salvage setting, blinatumomab doubling the marrow CR rate compared to intensive chemotherapy. And on the right side, I show the results of inotuzumab, which is a CD22 monoclonal antibody conjugated with galicheamycin, and it also doubles the standard the CR rate compared to standard of care. But we realized very quickly that we're going to be paying a lot of money for not much of a long-term benefit. So this is where we decided, let's not use the antibodies as FDA approved. Let's use them as we think is the best use, so in combination with chemotherapy, and not only in the setting of salvage, but also in the frontline setting. So having done this, I'm showing the results in the younger patients. So now these patients are 60 or younger, not just the adolescent young adults. And what you see is now we are expecting an estimated 10-year survival, which is close to 60%. In adult ALL up to the age of 60, which is unheard of in the past. And that's because we incorporated not only rituximab, but also blinatumomab and inotuzumab. So this is our frontline regimen with the hyper-CVAD blinatumomab, and this was before we added the inotuzumab. We published on the results in the first 38 patients. So these are patients up to the age of 60. And the total duration of therapy now is very different. It's 4 intensive chemotherapy instead of 8, and the maintenance is only 1 year instead of 2.5 years. So what you see is the CR rate is universal, MRD negativity is universal, because we have good experience with the hyper-CVAD since 1992. The 60-day mortality is 0. And what you see is now the estimated 3-year survival is close to 75 to 80%. So we're hoping that as we're learning how to use these drugs, it will improve actually in time rather than worsen in time. And we just added the inotuzumab to the intensive chemotherapy in the first courses. So this is older ALL. So now we're not talking about childhood ALL or adult ALL up to the age of 60, but those older patients who cannot tolerate intensive chemotherapy. And since 2010, we started treating them with mini CVD, blinatumomab, and inotuzumab. So a mild chemotherapy regimen with the cocktail of the 2 antibodies that were discovered. And what you see here is the data in the first 130 patients. And if you look at the estimated 5-year survival, it went from 25% to over 50%. 50% is what we used to get in adolescent and young adults as well as adults with ALL. So there's no doubt that we have a major breakthrough in our hands, which can be further improved in older ALL. So here I show the data in the first 70 patients that were treated with mini CVD enoblina. Universal marrow CR rate, 98%. We lessened the chemotherapy, so the early mortality is 0%. And then MRD negativity also is universal, 96%. And when we compare the old hyper-CVAD to the new mini CVD, even though we're using much less chemotherapy, we're almost doubling the 5-year survival rate. This is before matching the patients, and this is after matching the patients. So similar data. Now, AML becomes now the toughest one to cure, even though paradoxically in 1970, it was the first of the cancers where there was a report of a cure rate of about 20 to 30%. So this is the old standard of care. Everybody talks about 3+7, followed by high-dose Ara-C, and then an allogeneic transplantation without a maintenance. I think this is a very poor standard of care, even though it's practiced in 90% of the United States and the world. Because if you use the 3+7, as shown in the previous slide, the estimated 5-year survival with the SEER data is 35% in the younger patients. In the older patients over the age of 60, the median survival is 6 to 9 months, and the cure rate is 10 to 20%. So a very poor standard of care that almost everybody is still adhering to blindly, simply because they think they cannot do any better. So since 2017, there are 10 agents that were FDA approved for the treatment of acute myeloid leukemia. Aside from midostaurin, all the other drugs have been actually developed and championed and led by the MD Anderson group. So gilteritinib, a very powerful FLT3 inhibitor, which we use now frontline in combination with chemotherapy. The 2 IDH inhibitors developed by Dr. Courtney DiNardo, which are used for the IDH mutated AML. Venetoclax, a very, very important drug, the most important backbone of AML therapy that we are using now to improve the outcome of AML in both children and adults. And this was developed by Dr. Marina Konopleva at MD Anderson. So how do we treat the younger patients? We do not use 3+7. We use fludarabine high-dose Ara-C, idarubicin, or cladribine high-dose Ara-C, idarubicin. We already have added venetoclax and targeted therapies, and we use 6 consolidations or a transplantation, and then 2 years of maintenance therapy. Notice maintenance therapy has become important because, again, the dogma in AML was that maintenance therapy does not work, but a recent study with oral azacitidine showed that it does actually work. So on the left side, I show the MD Anderson estimated 6 to 7 year survival in the younger patients, 50%. And this is before we added the venetoclax and before we added the FLT3 and IDH inhibitors. In the older patients, we are improving the survival, but we're not curing many of the patients. But this is, again, before we added the venetoclax and the FLT3 inhibitors. So keep in mind that with the old therapies up till the age of 2015, the estimated 5-year survival in people 60 years or older was less than 20%. So this is very fresh data with the FLAG-IDA venetoclax that we just reported at the recent ASH meeting, and Dr. Lakowitz, who's a fellow at MD Anderson, reported on it, and we submitted it to the JCO. So the FLAG-IDA is combined with venetoclax in both refractory relapse AML and as well as newly diagnosed AML. I'm going to focus on the 30 patients with newly diagnosed AML to show you how much better we are. So now the CR rate is again universal. MRD negativity is also universal. The 12-month survival is 85%. And I show on the left side the early survival, but notice the refractory relapse. The refractory relapse with this regimen, 75% of them achieve a marrow CR, and we send them to transplant, and we're starting to cure quite a bit of them. Almost half of them which attests to the power of this drug. This is another regimen that is being tested in parallel by Dr. Tapan Kadia. So cladribine replaces fludarabine here because single agent cladribine is quite powerful compared to fludarabine. So a same strategy of cladribine, idarubicin, RC with venetoclax. And he reported again at this ASH meeting in the first 31 patients who were treated, universal CR rate 90%. The 8-week mortality is 3%, so there's a price to pay. But notice it's not, so this is the 8-week mortality of 3%. It's not the 4-week mortality of 12 to 30%, which I showed you outside of MD Anderson. And this is all the credit to the environment in which the patients are being treated, a major credit to the emergency center physicians, the ICU physician, and the supportive staff. And now again, a 12-month survival of 81%, and which we hope will continue. And if that continues, then we will be able to hopefully claim soon that in people under the age of 60, either the FLAG-IDA venetoclax or the CLIA venetoclax will be curing upward of 60 or 70% of the patients, rather than the 35% that were reported with the 3+7 and with transplant. The last leukemia I'm going to discuss are older patients with AML. This is where, in fact, we are starting to make progress. So what we did over the years is we developed hypomethylating agents as epigenetic therapy. This was developed on an investigator IND of decitabine at MD Anderson starting in 1992. As you know, decitabine is now FDA approved for the treatment of MDS, and also the most commonly used drug for the treatment of older AML. Now, the breakthrough came with the development of venetoclax. So I'll show you some of the data that Courtney DiNardo just reported. But I think more importantly, even though azacitidine venetoclax is today considered the standard of care in older or unfit patients with acute myeloid leukemia, I think it's already outdated. And here is why. Because now we developed a triple nucleoside therapy, cladribine, cytarabine, and either azacitidine or decitabine, and we added the venetoclax. And here I show you the results in the first 48 patients. So what you see is now we get a marrow CR rate which is as high as what we get with intensive chemotherapy in the younger patients. The mortality at 4 weeks is 0% at 8, so it's not the high mortality that's reported in the SEER data or in the cooperative group trials. Even at 8 weeks, the mortality is 40%. Now look at MRD negativity by flow cytometry. Now we can get MRD negativity in most of the patients. So this is the update at the ASH meeting, 55 patients that were treated. These are all patients over the age of 60. We included few patients which were unfit under the age of 60, but the median age is 68 years. Again, a marrow CR rate of 93%, MRD negativity 85%, and look at the survival at 1.5 years. 60% of the patients are alive. And then here I show the outcome by the ELN subsets. So the unfavorable, which are shown in blue, now are living quite well. And most importantly, if we can get the patients to stem cell transplant, they still do much better than without the stem cell transplantation. And here I show finally the survival in the patients with de novo older AML. So these are patients 60 years and older who have de novo AML. And what you see is that at 1.5 years, 70% of the patients are alive. But even in the secondary AML, so patients who progress from MDS or have therapy-related AML, we're still maintaining close to 40% of them alive at 1.5 years. And that's very different from what I showed you historically, where the median survival was 6 to 9 months, and where at 3 years, less than 10% of the patients were alive. So thank you for your attention, and I'm happy to answer any questions.
So thank you very much, Dr. Kantarjian. This was a wonderful update, and in fact, how many new therapies you have for leukemia patient, and how much you and the department has done to move forward this stuff. And also, I was very happy to see that the former discovery of my mentor, Carlo Croce, BCL2, targets of miR-15/16 are so important now to be targeted in leukemia. And with this, I have one important question, I think. What are the markers that you are using in order to understand if the patient with these new therapies are going on the right direction? Now with all this new advent of sequencing, deep sequencing, DNA, RNA, and so on. So if you can give us a hint on where you are on the predictors of therapy response.
So of course, it depends on the particular leukemia. In chronic myeloid leukemia, therapy has trumped all markers, so there is nothing that distinguishes the patients in terms of their survival. In chronic lymphocytic leukemia, it seems to be the same. The two predictive markers used to be FISH positivity for 17p and 11q23, and the immunoglobulin heavy chain mutation, yes or no, and then the molecular was the TP53, but it seems that the ibrutinib-venetoclax combination has already overcome most of those predictive factors. In acute lymphocytic leukemia, we have several of them that we have developed. So the Philadelphia-like, which I have not discussed because of the time, but most importantly, the MRD status in ALL, and this is where we're trying to develop a next generation sequencing to detect disease at 10 to the minus 6 rather than 10 to the minus 4. And maybe this will become the target of therapy. And then instead of giving a duration of therapy, which is fixed for 1.5 years, we could shorten it to a year or prolong it if needed, if the PCR remains positive, if the next generation sequencing remains positive to higher than 10 to the minus 6. In acute myeloid leukemia, there's a wealth of cytogenetic and genomic data which is guiding us. So as you pointed out, because of the discovery of the FLT3 and IDH mutations, we have developed the FLT3 and IDH inhibitors. Because of the discovery of the BCL2 overexpression in AML, we have developed the BCL2 inhibitor venetoclax, not only in AML, but in CLL, and we're trying to develop it in acute lymphocytic leukemia. So we're relying very heavily on the genomic profiling of the patients, and Dr. Takahashi is doing genomic profiling at the single cell level to tell us why some patients relapse and with what kind of clones so that we can target them upfront. So for example, he has shown that even in patients with wild type FLT3, 20 to 25% of the patients will relapse with FLT3 mutations. So this speaks for the need to incorporate FLT3 inhibitors into the frontline therapy, not only in the FLT3 mutated AML, but across all AMLs, because this could reduce the relapse in 20 to 25% of the patients. So these are the directions which I think we're taking on and discussing. So I have a question from Dr. Peter McLaughlin, who I forgot to mention. Actually, Peter was a fellow when I came as a visiting doctor in 1978, and he was an attending, and he mentored me in lymphoma when I came in 1981, and we had some nice publications too together. So his question is, with the long-term survival you're seeing, are there survivor issues that you're seeing? I think we're in chronic myeloid leukemia, we're seeing some issues of vaso-occlusive disease and cardiovascular problems with the TKI. That's why we reduced the dasatinib to 50 milligrams. We give everybody baby aspirin and we monitor them closely. In chronic lymphocytic leukemia with the ibrutinib venetoclax, we're not seeing anything adverse yet. In the acute lymphocytic leukemia, actually, we're seeing much less toxicity because we're using much less chemotherapy. And now the course in acute myeloid leukemia is going to unravel itself as we have more patients on the newer regimens like the FLAG-IDA venetoclax and the cladribine low-dose Ara-C azacitidine with venetoclax. So in acute myeloid leukemia, we have not unraveled yet the long-term toxicities, but we are definitely seeing many more patients who are living longer, and this may unmask a different natural course of the disease since the patients are living longer.
Another question. So excellent progress in treatment of leukemias. In your opinion, it is possible that some maintenance therapies that are effective in AML may be suitable for prevention, delaying relapse in some high-risk solid cancer, breast, prostate. Examples may be low-dose Aza-C, 6-MB, and so on. The case to inhibit resistant cancer cells in a timely manner without destroying immunity.
I think that's an important question. So as you know, when Dr. Jean-Pierre Issa was here at MD Anderson and we developed epigenetic therapy from 1994 till he left in 2008, he advocated that actually epigenetic therapy could modulate the cancer cells across all cancers, and he advocated for the use of epigenetic therapy with checkpoint inhibitors. I think there were some hints in other solid tumors, I think lung cancer and others, where the combination of epigenetic therapy with checkpoint inhibitors might work. So somebody needs to test them and see what happens. Another question is how important would be CD33 and CD123 in AML? This is from Dr. Stefan Stelasdek. I think they are going to become very important. So I did not detail the fact that gemtuzumab ozogamicin, the CD33 antibody, has increased the potential cure rate in core binding factor leukemia from 50 to 75%. So if we can develop similar antibodies that we can use in the setting of minimal residual disease, this will be a breakthrough. So people may not have realized that SL401, the CD123 antibody bound to diphtheria toxin, was developed at MD Anderson by Pemarajo. He reported this in the New England Journal of Medicine for a subset of leukemia called blastic plasmadendritic cell neoplasm, BPCDN. So now we're developing another antibody which targets CD123 called IMGN. It's easier to give than SL401. We're going to target also an FDA approval for BPCDN, but I think this will be a drug that we will build upon in acute myeloid leukemia. So I'm very excited about the developing of this new antibody, which is given as an infusion once a month in combination with other drugs, and it may further improve the outcome of AML with minimal residual disease.
Thank you. Only one point. So Ștefan Sedlacek, who sent you the question, it's a wonderful colleague and scientist from Romania. So the MD Anderson family, it's everywhere, and he was listening from all over the world. So another question. Can you comment on CAR T-cell therapy to control AML?
So far we have not had good success with CAR T-cell therapy in AML. We see a lot of cytokine release, a lot of toxicities, and very modest response rates in the range of 20%. So maybe that's because this is the first generation CAR T cells. Perhaps if we develop CAR T cells targeting dually CD33 and CD123, we'll have a better luck with this. So far we are gambling more on the conjugated antibodies such as IMGN 632. We have tried bispecific antibodies in AML targeting CD33, 123. We have tried CAR T cells, and so far it's not a breakthrough, but we're continuing the work, hoping that the new CAR T cells will be better. Also, this is where Nitin Jain is working with Dr. Nilapu in the lab to try to develop longer-acting allogeneic CAR T cells for acute myeloid leukemia, and we're looking forward to that collaboration.
Thank you. Also, one more question for Dr. Varsha Gandhi. Fantastic overview. How do you think we need to tackle cost of these agents?
So I don't have the answer. As you know, Varsha, I started discussing the cost of cancer drugs in 2012. So 8 years later, I think the drug companies have won. Now drug cost has become a political agenda issue, and I think people are aware that it's becoming a serious issue because older people on Medicare have to pay 25% out-of-pocket expenses for the new treatments, so they cannot afford them. And the same applies to the younger patients where the out-of-pocket expenses are higher. So I think maybe a legislation that allows Medicare to cover outpatient targeted therapy will help. But also we have to move to universal health care where we give the option of private insurance as well as a government-sponsored public insurance like Medicare for More or Medicare for All. I think that's the hope in terms of absorbing the cost of drugs. But there's no doubt that even though the United States makes almost all the discoveries in cancer research, we pay at least 2 to 5 times more for the drugs than they pay in Europe and elsewhere in the world.
Thank you very much. Very important point. And now let's have one more question and to come back to our beloved CLL. So for the CLL patient on MD Anderson trials, did you show relapse or progression into Richter syndrome?
So far, as I showed in the first 80 patients treated with ibrutinib venetoclax, they almost all universally go into a complete molecular response. We have stopped almost all of them now with a median follow-up of 18 months. We're seeing a slight molecular relapse in 2 or 3, but the others are not relapsing. So I really think that this is a true magic combination of 2 non-chemotherapy drugs which are curing the majority of patients with CLL. So yes, we do occasionally see Richter's transformation, but I think that combination of BTK inhibitors with BCL2 inhibitor is really working extremely well for CLL. I remember Keating in 2004, it was at Freyrak's 70th birthday. We had a Freyrak Festschrift. And Keating was talking about CLL, and he said, I wish I had a drug for CLL that's as good as Gleevec for CML. And his wish came through because I think ibrutinib venetoclax is much more powerful than BCR-able TKIs in CML because that combination is given for a finite duration of therapy of 2 years, and the patients are not relapsing after stopping therapy. So to the credit of Michael Keating and his group, MD Anderson has developed the curative therapy for CLL.
Thank you very much. And for all the attendees, please, other questions, direct them directly to Dr. Kantarjian. Very sure he will answer. Thank you, Dr. Kantarjian. It was a wonderful lesson on how you can save lives doing at the best clinical therapy. And also I want to thank you because in fact it was wonderful that you name your mentors and you name your colleagues who move forward the leukemia treatment with you. And with this, we will continue the spring Enjoy Science session in 2 weeks from now. You can see here all the wonderful speakers who will move forward. And of course, happy Inauguration Day, and let's hope the next 4 years will be the best for science and medicine ever. With this, thank you again, Dr. Kantarjian. Wonderful to have you here. And thank you all of you. You were over 200 today who was listening the talk. Thank you and see you in 2 weeks from now.
Thank you for hosting me.